Good afternoon and good morning to others. I'm Bill Hoagland, Senior Vice President at the Bipartisan Policy Center. I have the pleasure of working with our health team here at BPC. Thank you for joining us today's panel discussion, Modernizing Medicare Part B Physician Payments. Today's event brings together some real experts from across the healthcare system to discuss how policymakers may have a pivotal opportunity to modernize our Medicare physician payment systems. We know that America's continuing chronic disease burden, coupled with an aging population, creates a challenge to a payment system that rewards volume over value and threatens both patients' outcome, clinician satisfaction, and particularly Medicare's long-term sustainability. But we think bipartisan concern over rising Medicare spending could create a legislative opportunity to strengthen physician payment, advance value-based care, and better support prevention and coordination. The administration's mid-session budget review released just a week ago projects that the Medicare spending will double from over the next decade, from nearly $1 trillion this year to $2 trillion in 2035. It is the fastest growing component of federal spending at about a 7% annual rate of increase. Today's panel will explore both the challenges and practical policy solutions to move us forward, reducing costs while maintaining, I hope, and increasing the quality of service through encouraging greater adoption of alternative value-based payment models. We will also touch on the need for Congress and the administration to advance bipartisan reforms that would address the need for annual interventions to adjust payment rates. We are fortunate, and I'm quite excited, honestly, to have such an excellent panel here today to discuss both the challenges and policy solutions. We are joined by Dr. Aisha Beaton, Stephanie Quinn, Dr. Bob Rauer, and Dr. Barry Arbunkel. Kendall Strong, our Associate Director of Health, will formally introduce them in just a few minutes. I want to take this opportunity, though, to thank Kendall, along with Lisa Hartushian, Aiden Kennedy, and Manali Niki for putting this event together today. At BPC, we have long championed and advanced what we believe are practical bipartisan solutions to strengthen Medicare. Our most recent report toward value and sustainability, along with several previous issue briefs, continues this legacy. This most recent report, by the way, is linked in the chat. It offers options to increase participation in value-based alternative payment models, to empower clinicians, improve patient health outcomes, and sustain and protect Medicare, again, for the long haul. I'll now turn this over to Lauren Kushner with Arnold Ventures and Connie Lewis with the Commonwealth Fund for a few opening remarks. Lauren?
Great, thank you, Bill. Good afternoon. I'm Lauren Kunstner, Director of Arnold Ventures Medicare Sustainability and Provider Payment Incentives Portfolio. At Arnold Ventures, we are excited to be supporting the Bipartisan Policy Center's work to strengthen Medicare and increase participation in alternative payment models. As some of you may know, Arnold Ventures is a policy-oriented philanthropy that makes strategic investments in a number of issue areas to advance policy that addresses pressing domestic challenges. We have a wide-ranging healthcare portfolio, but the unifying thread across Sorry, I think that I was muted for a second there. We have a wide-ranging healthcare portfolio, but the unifying thread across portfolios is our focus on improving affordability and reducing wasteful spending. Our work in Medicare physician payment falls within the portfolio I lead, where we aim to improve the efficiency of the healthcare system, shift away from fee-for-service payment, and use payment reform to ensure more personalized, high-quality care for patients. We're focused on advancing the adoption of effective alternative payment models like ACOs that hold providers accountable for the cost and quality of care. We know primary care plays an important role in successful ACOs and support moving to hybrid capitated payment for primary care. We are focused on strengthening financial incentives for clinicians to participate in population-based models, including by widening the payment differential between fee-for-service and advanced alternative payment models, or by extending and restructuring bonus payments for advanced alternative payment model participants. We support research and policy development on comprehensive physician payment reform to develop more sustainable and fiscally responsible physician payment updates. We also support work to rebalance the Medicare physician fee schedule and ensure accurate valuation and payment for primary care on the fee-for-service side. We are encouraged by the recent policy momentum on efforts to rebalance the fee schedule away from specialists and toward primary care and remain committed to Medicare physician payment reform. Before I wrap up, I'd like to thank the team at the Bipartisan Policy Center for organizing today's meeting and their work to modernize Medicare's physician payment. I'd also like to thank the Commonwealth Fund for their collaboration and shared support of this work. And finally, I want to thank all of you for your commitment to this issue. I will now turn it over to Corinne.
Hi, everyone. Thank you all for being here, and thank you to the Bipartisan Policy Center, Arnold Ventures, and the panelists for making today's event possible. I'm Corinne Lewis. I lead the Commonwealth Fund's work to improve care delivery with a focus on strengthening primary care and rural health. For those not familiar with the fund, we are a national nonpartisan foundation dedicated to affordable, quality healthcare for everyone. We have been focused on primary care for many years because it plays a unique and indispensable role in our nation's health. But the future of primary care is at risk with access waning and provider burnout surging. Evidence and experts point to a root cause of this crisis, the broken payment system. We do not pay in effective ways, and we do not invest enough in primary care, particularly considering its clear value for health and the overall efficiency of the healthcare system. As one of the largest and influential insurers, Medicare plays a really critical role in leading the way to change how and how much we pay for primary care. Really appreciate BPC's leadership to identify solutions, and looking forward to today's discussion around improving Medicare physician payment more broadly and how we can strengthen primary care payment within that specifically. And I will turn it to Kendall for the panel.
Thank you both, Corinne and Lauren, and thank you, Bill, for those opening remarks. My name is Kendall Strong, and I'm an associate director here at the Bipartisan Policy Center, and I will be moderating our conversation. I'd like to welcome our panelists to the virtual stage and introduce them, and then jump into today's discussion. As a reminder to the audience, please utilize the Q&A function throughout the event if you have questions for our panelists, and I will also leave some time at the end to take questions. Today, we are joined by Dr. Asaf Bitan. He is the Executive Director of Ariadne Labs, an Associate Professor at Harvard Medical School and the Harvard T.H. Chan School of Public Health. In addition to being a practicing primary care physician, Dr. Bitan has led major domestic and global efforts to strengthen primary care payment and delivery, including co-chairing the National Academy's Primary Care Payment Work Group. Stephanie Quinn joins us. She is the Senior Vice President of External Affairs and Practice Experience at the American Academy of Family Physicians, where she leads government relations, practice advancement, and strategic engagement to support family physicians and the communities they care for. She brings today extensive experience in federal health policy and advocacy, having previously held leadership roles at CareFirst Blue Cross Blue Shield and the American Society for Radiation Oncology. Dr. Bob Ronner is joining us from as president of Partnership for a Healthy Nebraska, which focuses on health policy and community-level projects to improve the health of Nebraskans. Over the last 13 years, Dr. Ronner has also worked to start 2 primary care-led accountable care organizations, the Southeast Rural Physicians Alliance ACO in 2012 and One Health Nebraska ACO in 2016, where he served as Chief Medical Officer until February 2024. Dr. Rauner started his medical career as a family physician serving rural and underserved communities for 15 years, and then transitioned into leadership and policy roles after completing his Master of Public Health in 2010. And last but not least, Dr. Barry Arbuckle joins us. He is the president and CEO of Memorial Care, a leading nonprofit integrated health system in Southern California. Under his leadership, Memorial Care has advanced value-based care through innovative partnerships while excelling in accountable care organization performance and healthcare innovation. He serves on numerous national boards, including the Healthcare Leadership Council. Again, thank you all for being here. To begin today's discussion, I'd love to dive in and get a better understanding of today's current Medicare Part B physician payment system. This payment system is often described as rewarding volume over value. So I'd like to start by asking each of our panelists in turn what you see as the biggest shortcoming of this traditional fee-for-service payment system. And I'll go ahead and start with Stephanie. From the perspective of clinicians that the American Academy of Family Physicians represents, can you speak to some of the challenges in operating within this type of payment environment?
Sure. When you think about primary care and what makes it successful, it's really that relationship over time. And if you think about the fee schedule, it's really a collection of codes and services. And so there isn't really an accurate way to account for how you build that relationship, how you maintain it, how just the comprehensiveness of that care over time. And so what happens is you begin to be rewarded for things happening and not things not happening. And really, when we think about wellness and prevention and chronic disease management, it's the lack of services that we're looking for. And so I think the incentives of a purely fee-for-service system are a little bit skewed. Not to mention, I think, in a broader context, budget neutrality in terms of there are only a certain amount of dollars to shift around. You are absolutely and very quickly going to get to a distortion within that if that's the cost containment measure of choice. And so when you think about primary care, resourcing them to take care of a population versus resourcing them to take care of a patient coming in, those things there starts to be distance between them. And so, I think this is something that we've been struggling with for a very long time.
Thank you, Stephanie. I'd like to turn now to Dr. Bitton and Dr. Rauner. Research shows that patients themselves are often facing fragmented care within a fee-for-service system. So in addition to what Stephanie spoke to, the impact on clinicians, can you speak to how patients experience this system?
Sure. What we hear, what we see with our patients is that, as Stephanie was saying, when you have the unit of service as being really principally in primary care and other outpatient specialties, essentially an in-person visit or now a telehealth visit, what gets paid for is what gets pushed from the budget and planning perspective. But of course, what primary care does, its benefit for patients and for society is about longitudinal, comprehensive relationships over time. Those relationships are more than 2 or 3 20-minute visits in a year. And part of the issue underlying all of this is that in the 80s, our modern Part B physician payment, and the reason we have a payment system sort of focused on visits is because we needed to have a consistent unit of measure that would measure physician work so that it could be paid within budgetary laws from OBRA in 1989. That work measure became to be called a relative value unit, and it came to really comprise physician effort, practice expense, and professional liability, with the predominance being effort. Now, effort is work was defined, for the purposes of trying to equally define a surgery and an outpatient consultation as being around the time and intensity things are required to get the work done. We can talk about whether that's a good or bad measurement system, but for the purposes of the discussion and for our patients, what's not in the way that we define work in Medicare fee schedule is that it's not based on the necessity of the service, the quality of the services, the health outcomes of the service, nor the cost of the service to the society or to our patients. And so I think that underscores why, yes, we need a consistent method of sort of measuring effort, but perhaps now it's time for both our patients and for society to look at better ways of encompassing what we mean by effort and what we mean by value.
Yeah, I'd say
Thank
that
you,
the
Dr.
part of
Baton.
I'd say the core problem is that primary care isn't designed around discrete billable events, and that's what fee-for-service is for. My family and I, we've seen my family doctor for 22 years. He's part of the ACO I left, actually. He gets paid a population-based payment to care for me. He has a team that makes sure that I get my vaccines or my colonoscopies or whatever so that he's available when I need them. That's the kind of care I want, and he gets paid for a team that does that with his alternative payments. And he's judged for accountability on the back end. If he's judged on whether he got me in what I needed to be seen, he's judged on whether he got me vaccinated and whether I've got my cancer screenings. And that's the kind of care we want for us. It's the kind of care I want for my mom and dad. And this is the system that rewards that. I think our problem is our system is based on insurance, and we insure against the things we don't want: heart attacks, strokes, car wrecks. We don't budget for the things we do want, things like good primary care and good prenatal care. And we know what that budget should be based on studying other health systems. It's 10 to 15% of the total healthcare pie. In Nebraska, or in the United States, it's about 4 to 6%. And that, I don't see how you get there on a fee-for-service system.
Thank you, Dr. Ronner and Dr. Baton. I'd like to ask a question of Dr. Arbuckle. You know, we've seen a growing prevalence of health systems opting to shift towards value-based and alternative payment systems. Can you speak to what the benefits of that are to a health system and why you think a lot of health systems are keen to make this shift?
Well, I think in part they see where that's where the puck is going, and they want to be in that space. They know we can't continue with the fee-for-service system in perpetuity. It's simply unaffordable. So we've got to pivot to something that makes more sense. And it's intuitively more attractive, I think, for health systems, including providers, that we're focusing on preventing some of these things that historically we've just been treating, and then the patient walks away and we wait till they come back. So it's a more comprehensive, integrated approach that I think appeals to providers within health systems. But it's also, from a pure business perspective, an opportunity to kind of stake out your ground in value-based care in your geography by getting there sooner, getting there first. A lot of the value-based programs that Memorial Care participates in, and we have participated in every stripe and style of alternative payment model that exists: the government ACOs, the upside ACOs, the downside ACOs, capitation, direct to employer models, and we've done so for now 10 or 12 years. Those tend to be more narrow network models where the employer or the consumer signs up for that ACO. They know they're a part of that ACO, which is one of the challenges we've seen with some of the government models that tend to use the attribution model, which is the patient doesn't know they're in the ACO, the physician doesn't know they're in the ACO until the patient shows up at the ER or the hospital. That's not the way to manage care. So getting ahead of these things is, I think, what makes it appealing to health systems.
Thank you, Dr. Arbuckle. So as we know, the Medicare Access and CHIP Reauthorization Act, what we all know as MACRA, passed with bipartisan support in 2015 and aimed to shift Medicare away from the traditional fee-for-service and towards an alternative payment model system that better rewards value. With these MACRA incentives now expired and renewed interest from the Trump administration and better supporting chronic disease prevention and management, as Bill opened, we see an opportunity for policymakers to make broader physician payment reforms. So Dr. Ronner and Stephanie, I'd like to hear from your perspective about how the recently passed One Big Beautiful Bill Act's provider payment provisions, specifically the temporary payment rate update, will impact clinicians, and more broadly, where you might see consensus emerging for longer-term approaches to clinician payment.
I'd say although every little bit helps, a 2.5% bump on 10 to 20% of your business ends up being a 1/4 to 0.5% incentive. That's nice, but it doesn't provide the critical mass to do the things you need to do. And because it's temporary, it's not something I could count on. And so you need a type of payment that I can plan on over years, and it's sufficient to hire the staff that I would need. You know, our clinics that were the best in our ACO, they went from a generalized care coordinator to a diabetes educator to a social worker. Adding those people, that doesn't happen with a little 2.5% bump. And so I certainly appreciate the increase. Every little helps, but it's not sufficient, and it's not going to move the needle.
And I think to build on that, and it's not predictable. And so when you think about it, I mean, I think fix is a bit of a misnomer, as I mentioned earlier, with budget neutrality. If you're shifting within that environment, the chance of distortion is huge. And so other costs continue to go up, as Dr. Rauner suggested. Staffing continues to go up. You need to be able to pay people that are going to help better care for your population. There's better technology, and without that predictability and stability, you're unable to cobble together the resources to be able to care for a population. And so, I think these things, while they are, attempting to address the problem, there's just a pervasive change that needs to take place if we are going to look for different outcomes, with primary care being at the center.
So in addition to Congress acting and maybe needing more action, the administration has also, had some signals that they seem keen to act and encouraging both participation in value-based care and ensuring the appropriate evaluation of this care. I'd like to ask Dr. Baton, as I know you alluded to earlier, can you speak to the value of empirical independent data in tackling these valuation issues in the fee schedule, as you talked about earlier, and why it is important beyond just fee for service, but for alternative payment models specifically?
Absolutely. The way that within Medicare, in terms of coming up with the fee schedule every year, which, by the way, has downstream effects on many other payers, commercial, Medicaid, Medicare Advantage. The way that it comes together right now is through a committee called the RUC that's convened by the AMA, and that has representation from each of 32 not always specialty societies. It has 32 representatives. The majority of them come from specialty societies, 4 come from primary care. They survey their members, and they send out very detailed forms, and they say, if you're in urology, if you're in family medicine, how long does it take you to do your work? The surveys are all self-report. They are all, people talking about their own work, which, sometimes leads to perhaps emphasis on, everyone thinks that they're busy, and they are. But based on these surveys, because the law says that you have to have a physician panel that uses empirical data and then runs through a process to sort of provide CMS with recommendations on what work is and how to value work. On the one hand, which is good, there's a single unit of measure, the RVU. On the other hand, there are some very serious questions about whether this panel, as an advisory body that has more than 90% of its recommendations accepted by Medicare, is providing the most useful empirically derived data. There might be other ways, as it's been introduced in an act called the Paid PCPs Act in the Senate Finance Committee last year. There have been discussions within Medicare, the Center for Medicare, and their updates to the fee schedule this year around using different forms of data in addition to the RUC, commissioning data, using different time and motion studies, other observable forms of data to try to get at a better way to value services that I think there's nearly wide consensus are misvalued or undervalued. Those services that we just talked about here in primary care, longitudinal relationship, comprehensive coordinated care. And so I think that that this may sound like a very technical issue. How do we value physician services? And isn't this a bunch of physicians just saying they need more money? It is actually way more serious and consequential than that, because if we don't value and measure the unit correctly, we get into what the other panelists have talked about as the distortions, the misvaluing, and the gaps in care and provision of the right resources to the systems that are now accountable for the health of populations.
Mm-hmm. Thank you, Dr. Baton. Stephanie?
Yeah, I think Dr. Baton actually covered a lot of what I was going to say, except that, I think the RUC itself has challenges above and below it. I think below it, as he mentioned, the data sources, I believe that physicians have a place in in determining the cost, that input is valuable. I think there are other data sources that can bolster and just give a more dynamic view of what is actually happening. I think the challenge with primary care versus something that may involve a procedure is that they're not discrete units. So it's going to be really hard to accurately assign value to that and what the value to the system is. I think above that, again, I keep coming back to it, is they are working within the confines of budget neutrality. They know this is the pot of money that has to be reallocated. And so it's a false choice to say that because this service is more intense or is now more expensive, that money has to come away from something else that is also needed in the system. It is the only mechanism in the Medicare payment system. Hospitals are not forced to make those choices and those shifts. And so I think for you to meaningfully get at how to revalue these things, we need to take a look at that as well. But it does come down to you're talking about thousands of codes. How do you really start to accurately assign that? You need multiple data sources and multiple ways to get a view.
And Stephanie and Dr. Baton, I think it'd be really helpful for our viewers to kind of understand what the linkage is between the fee schedule and the valuation of codes and how this translates into the shift towards alternative payment models. Can either of you speak to that a little bit?
Yeah, I mean, again, I think it's not fee for service or value-based payment. Every single value-based payment that I'm aware of uses, even in an abstract sense, the fee schedule as a reference point, whether they're moving it up or down, whether they're giving a prospective payment, they're making assumptions about the value of the bundle of services that they're including in that prospective payment. So if you have distortion in that underlying structure, you're going to be incredibly challenged to design a payment model that accurately and appropriately resources primary care.
Thank you.
Yeah, and this distortion, I mean, the question then becomes, if you are moving away from just paying for the unit of visit in primary care or unit of procedure, so on the one hand, it's sticky. People want to keep doing it because it's easy to measure, it's easy to count up RVUs, it's kind of predictable. The harder you work, the more money you get. But the focus is really on doing things to people, as opposed to putting teams together to care for a person, her trajectory over time. What the shift to value offers you the opportunity is to pay by outcomes, by quality achievement, by things that matter to patients and to society. That it has a putative sort of cost control mechanism, which we have to talk about as we spend over $5 trillion a year on healthcare, and that money is coming straight out of job growth and wage growth and bridges and schools and other good things we want. And so, the other thing about value is that, measures quality, measures outcomes, but it also encourages coordination and integration of care, which unit-based, visits do not. You just do more visits, do more procedures in fee-for-service. In value, and you heard this by all the panelists, what you're encouraged to do is care for the person's needs. 80% of Medicare beneficiaries have more than 2 chronic conditions. By definition, they have complex, multi-morbid needs that require that weaving. That's why primary care is so important for Medicare beneficiaries. And yet the idea that Medicare can really provide sustenance for primary care off of 3% of its total healthcare spend, and that's what it is, three and change, is just not enough in this zero-sum game that Stephanie's talked about to really get the work done and have teams be there with predictable payment to provide excellent service.
Thank you, Dr. Baton and Stephanie. I'd like to go ahead and shift the conversation now a bit to how we get to this value-driven payment system. And I'd like to open up the floor to Dr. Ronner and Dr. Arbuckle. And we talked about this a bit earlier, but the narrow payment differentials, or gaps as we often call them, between the fee-for-service system and value-based alternative payment models have slowed the adoption of APMs. At the same time, I know Dr. Arbuckle has spoken about this, just the number of different APMs that are available has often been cited as a source of confusion and complexity and uncertainty for clinicians, and taken together, we've heard can discourage clinicians' participation in these models. So Dr. Ronner, BPC recently recommended that Congress extend and restructure the advanced APM bonus payment. We also recommended some efforts to streamline, models and designs and potential weaknesses. Are there other reforms that you think would make participation in APMs even more attractive for clinicians?
Yeah, I think one of the most essential thing is a significant population-based payment. We got our AC off the ground because a lot of our clinics were in the CPC Plus program, the CMMI, that gave them a population-based payment, and then because it was a multi-payer, our largest commercial employers also paid that same payment. That's what allowed us to hire the care coordinators and build up our infrastructure. That has all now gone away. The CPC program was sunset. Now the primary care first. Now the good news is the ACO got to the point. I just looked at the last few weeks ago. They were 9.25% under budget, which is great. The problem is that's the last year 5 of their second 5-year contract. What if their benchmark gets ratcheted down that 9.25%? So that money's gone. The population payment's gone. Now will it all fall apart? And so the system we built the system, but now the system has to transition to that population-based payment that'll sustain it, or keep the benchmarks adjusted, which gets a little wonky to try to explain benchmarks. There's probably not enough time for us to go into that here. But unless you fix those problems, what is a great system is going to fizzle because you failed to sustain it with that population-based payment.
Dr. Ronner, we're going to have you back to talk about benchmarks, but Dr. Arbuckle, what reforms would make participation, you think, more sustainable and attractive for clinicians and health systems? And what do you think Congress and the administration could be looking at?
Well, I think as has been touched upon already, the incentives and the investment need to be significant enough to allow the provider organizations, health systems, or physician groups to invest in an infrastructure that's different from a fee-for-service infrastructure. We've all heard the old idiom of a foot in the canoe and a foot in the dock. That's an uncomfortable place to be in general. And it's also an expensive place to be because they require different infrastructure. So we need to focus on those incentives. As Dr. Ronner had touched upon, these programs need to last longer than they have historically. For provider organizations to jump into them, they need to know they're going to be there for a while. And it's also going to take some time for them to show their value. And we've seen some of that in some of the analyses of some of the past programs. I mentioned a moment ago the models, the attribution model, which again, the government has chosen to go to because it's a little bit less intrusive or perceived to be, as opposed to a network model where patients actually sign up. They sign up with a provider. They know who it is from the start. You can immediately begin outreach and prevention and education and coordinate care more effectively. We need to evolve to that. I think the providers are ready for it. And then finally, and this is something we observed a number of years ago and have made some progress in, but there's a lot of room to go, and that is with the variety of alternative payment models, both in the government sector as well as the commercial sector. All the payers use different measures and metrics. And for a primary care physician or a provider organization to try to figure out which depression measurement am I using to measure for this patient, and what time frame do I use to look at remission, 30 days, 90 days, 120 days, it's mind-boggling. And some will just say, it's too much work. I'm going back to the old fee-for-service methodology. That's not what any of us want. And so we need to harmonize the measures and metrics as much as we can.
Thanks, Dr. Arbuckle. I'm so glad you brought that up, because to shift us with our remaining time from financial concerns, I also want to talk about the administrative burdens that clinicians often cite as frustrating in terms of the alternative payment model system. While Congress and the administration have achieved, certainly some progress towards more streamlined and meaningful quality measures and EHR requirements, we know that these burdens persist. So I'd like to open this up to all panelists, but maybe Stephanie, you can start. In your mind, what do you think would make quality measurement reporting feel less like a compliance exercise and more like a clinical tool?
Yeah, I mean, you kind of touched on it. I mean, alignment and streamlining of reporting are certainly important. I think that is a pain point, but that's not enough. I mean, many of them are structured as cliffs, and I think if you think about true quality, some of it is incremental, and moving along that trajectory is important, just as is sustaining quality. And so the rewards need to be there so that sustaining high quality is rewarded appropriately. And right now it seems to be a singular destination that you either have achieved or you have not. So, I think that, and again, the lack of alignment for all the differentiation in the system I wouldn't say that any one payer, Medicare, Medicaid, or any commercial payer, that their diabetics are any more well measured, or depression is screened any more effectively to warrant the level of differentiation that we see. So there's really got to be some alignment in those, and also an alignment in the incentives to accomplish those. And that comes from the system level all the way down to the clinical level.
Dr. Ronner, can I ask you how you think policymakers, kind of speaking to what Stephanie said, can strike the right balance between reducing burden, but also making sure these quality measures are not burdensome, too burdensome?
Two things. One is to have a consistent, parsimonious, meaning maybe 10 to 15 measures that you have to do. At our national ACO meetings, we used to explain about what we called the grid, which was the multi-sheet spreadsheet of all the measures from all the different plans, and everything was defined differently, and it's almost impossible to manage, and it's really expensive to manage, and it's really hard to align your quality improvement if you're pulled in so many different directions. And so coming up with, and a lot of states have actually done this. Nebraska actually has what we call the aligned metrics. I know California, CalPERS has set up sort of a common metric. They tend to be very similar for very, very rational reasons. So come up with a set that makes a lot of sense. And we've been, the industry's been asking for this for almost 10 years now. The second is the cost of pulling these measures, because there still is not interoperability that was promised, meaning to use more than a decade ago. There still is not consistency in how an EHR runs those quality measures. And so it's gotten really expensive for an ACO to report those measures, even once you're up and running. But starting from scratch, it's almost cost prohibitive to start a new ACO just because of the cost of pulling all those quality measures.
Thank you, Dr. Ronner. And Dr. Baton, in addition to the quality measure reporting that we've just talked about, we've also heard concerns about electronic health record interoperability. And for folks who don't know what that means, that is the ability of different health information systems to talk to each other and share information. But CMS recently introduced a voluntary data exchange framework to improve data exchange across payers, providers, and care settings. Building on this, what other steps do you think that HHS and Congress should take to advance the EHR interoperability system for clinicians?
Well, thanks so much. And just so people aren't falling asleep before their lunches, this may sound super wonky and in the weeds, but it's critically important, and there are billions of dollars in this question. The issue really is at a very fundamental level. If you're seeing me at my clinic tomorrow, do I have access to what's happened at Dr. Ronner's clinic, or through your oncology journey, or on and on and on? And we've been promised this. We have spent billions as a country on these massively expensive, complex systems, and yet we cannot guarantee you today that what happened to you yesterday, even in some of our own adjacent systems, can be correspondingly documented in even the most simple format. So what needs to happen, and I think this is really public-private partnership, needs to kind of coalesce and not get glassy-eyed and bored by the technical complexity, but just focus on the fact that we need complete data across payers and different provider systems with fewer measures that ensure that everybody's records and history gets fairly transmitted at the point of care when and how they need it, and to registries that help point out gaps in care. This would require the adoption of consistent standards. If you want to get technical, FHIR standards, FHIR would be a great start, as well as some other core data for interoperability that have been talked about and there's general technical agreement on, and even some of the semantic alignment within the subcode structure. But there's, quite frankly, the need for policy and system levers to sort of ensure that these standardization protocols and languages are used, that vendors that sell these incredibly expensive EHR systems at quite a premium actually are held to account for interoperability as was defined originally in the statutes and the rules, and that there may be some disincentives to not being interoperable, and that provider systems stop acting like closed wall houses and see the benefit of communicating with each other. Because as Dr. Arbuckle said, you cannot have someone attributed to you if you don't know that they were attributed to you, or you don't know what happened to them outside of your attribution lake. So, I think that this really requires policymakers to lean in. It is a wonky issue, but shifting our whole quality measure apparatus from claims claims-based things that happened in an insurance claim 6 months ago to real-time quality measure with fewer measures on a single reporting standard that are validated and audited and that have cross-system aggregation can really open up the potential for value-based care to do what it's supposed to do.
Thank you, Dr. Baton. And I'd like to ask Dr. Arbuckle now, in terms of your experience with health systems and what has worked best, maybe specifically for Memorial Care, and what challenges remain for you all in this space?
Well, for us, it's really about trying to get up to scale in the value-based care models, whether it be Medicare Advantage or one of the CMMI products or the commercial side or direct to employer. So we have that, we can justify that infrastructure and continue to kind of work those muscles that are fundamentally different from what virtually everyone in the health system has done for their entire careers. So that's been effective. I think some of the points we've already raised, the EHR and now the incorporation of AI is truly I think they show great promise. I mean, by one example, we've incorporated a year ago the ambient scribe, which allows the patient to interact directly face-to-face with the physician in the office rather than over on the computer tapping things in because they're required by this, that, or the other payor. And they have that interaction all the while the cell phone, very simply, in multiple languages, if necessary, is condensing that dialogue between the patient and the doctor into something that can go right into the medical record. It can assist with the proper coding, and it can even pick things up, which to me is just phenomenal. As they're walking out of the room, imagine the patient and the doctor walking out of the room, and the patient just makes an offhand comment, "I need to go visit my mom. She's experiencing some challenge with COPD." Bingo, there's a connection there that was just made that the scribe can actually do on its own. And it incorporates artificial intelligence, so it does it in a smarter fashion. What we've seen from our physicians has been powerful. They're saving upwards of 2 hours a day in documentation, which means they can spend more time with their family, they can actually take a lunch break, or they can see a few more patients a day, whatever their choice is. The patients like it better because they're feeling the doctor is actually listening to them. So this kind of evolution we need to continue to embrace because it's going to make a big difference, I think, in how the healthcare system in the United States works.
All right, so at this point in our discussion, as I feared, we may have run short on time for audience questions, but we've covered a lot thanks to our experts here today. We've talked about policy solutions and key challenges, both in terms of payment and practice. And really, to close out today's discussion, I'd like to ask each of our panelists in turn what you think we need to take from past efforts at physician payment reform and how we can apply those lessons to current and future efforts. I'll start with Dr. Baton.
Well, thanks so much. What I would say is that we have a reflexive cynicism that nothing can change. We've seen this before, and just we have to accept our expensive, mediocre outcomes. And I would say that change starts with rejecting the kind of comfortable, cynical position that nothing changes. Look, it's very clear we have A+ evidence that fee-for-service is just not working for large swaths of our patient population and our clinician population that are trying to care for people over time through relationships and comprehensive care. So if we know that, then we know what we need to do next, and then it's a question of will. And if it's a question of will, then we can't reflex back to cynicism.
Dr. Arbuckle or Dr. Ronner?
I'll just say 3 words in these lessons from the past. Simplicity. We can't overwhelm the provider system with inordinately complex systems. So simplicity, transparency is key, and the availability of data as real time as possible. And then finally, sustainability. The providers need to know that this model is going to be around for a while so they can really lean into it.
Yeah, I would say we need to finally move to a consistent multi-payer population-based payment to provide that infrastructure to hire the care coordinators, the social workers, the diabetes educators to really allow you to provide great primary care, and then hold them accountable on the back end. Doctors are not afraid of accountability, but make it make sense. A nice parsimonious set of measures around quality, the patient's experience, utilization, they'll perform like the primary care-led physicians have been performing year after year in the Medicare program.
And Stephanie, I'd love for you to close us out here.
Yeah, I would say that it comes down to alignment, alignment of incentives within a system and supporting those practices, making sure they have the resources they need. And I also think it takes multi-stakeholder support and buy-in that this is a better way forward. And then we have to address the workforce. That is a separate issue entirely, but I think creating access will be key to success as well.
Thank you. Well, to wrap up today's conversation, I just want to thank our panelists again for sharing your insights and your expertise. And again, I want to thank the Commonwealth Fund and Arnold Ventures who made today's conversation possible. We look forward to continuing these conversations and collaborating with all of you. If you have any questions, if you're in the audience, please reach out. And thank you so much for joining us today.